Hello, everyone, and welcome to our International SADS Conference. I'm Genevieve Eccles, the Family Support Director at the SADS Foundation. While I'm disappointed that I can't be there with you in person due to medical treatments, I'm extremely excited to welcome you and tell you a little bit about the program we have planned for you over the next day and a half. Our team at SADS spends the entire year thinking about and planning our program based on feedback we hear from the community and needs we see. You will have the chance to hear from the leading experts in SADS conditions and have time to ask your questions. You will also hear about the advances in science, newest treatments available, and current clinical trials. We have also invited mental health experts to help guide you in making sure you and your children are supported in your mental health. We hope you will enjoy conference, gain the knowledge you need to live and thrive with your SADS condition, and make lasting friendships with others in the community. If you have any questions or any comments, please feel free to reach out to any member of the SADS staff, and they would be happy to help you.
Can you guys hear me? Yep. Well, thanks everyone for coming, and thanks for having me. Those who drove in Chicago, welcome. My name is Jeff Hong. I'm an electrophysiologist. Review of how our hearts work, okay? Talk about a few things here. We'll talk about parts of our heart are organized. Sorry, we are going to talk about the anatomy, is that better? And the structure of our heart, or how our heart is physically organized. We're going to talk about the conduction system of our heart. We're going to talk about the specific structure of our heart muscle cells. Finally, we're going to talk about what happens during a cardiac. Start by talking about anatomy. Test. Working? Okay. So we'll start by honing in on in this general structure of what main chambers, top chamber, right? Test. All right. So going back, there's two top chambers of our heart, the right atrium and the left atrium. Their responsibility is to receive blood from the body and from the lungs, and then to deliver the blood to the bottom chambers. Bottom chambers are our right ventricle and our left ventricle. Okay, the right ventricle is responsible for pumping blood to our lungs, and the left ventricle is responsible for pumping blood to the rest of our body. So if we go on the journey of a red blood cell, so here is a single red blood cell. There are millions and millions of red blood cells in our body, okay? So this red blood cell has just come back from our body. It has delivered oxygen to our body, and so it is a deoxygenated blood cell, okay? I'll put in a picture of the brain and the lungs just to be a little more complete. So the red blood cell is first going to travel to the right atrium. It's then going to be delivered to the right ventricle. The right ventricle is going to pump that red blood cell to our lungs. The lungs are full of oxygen that we breathe in. The red blood cell then picks up that oxygen from the lungs. Okay, so now we have an oxygenated red blood cell. That blood cell comes back to the left atrium. Then it goes to the left ventricle, and the left ventricle is responsible for pumping that blood to the rest of the body. So this blood cell goes to the brain and delivers oxygen to our brain, okay? Now, all of these parts are working simultaneously, right? It's not one working after the other. So think of like an assembly line, right, for cars where every single part does its own job over and over again. And so here's a quick video of what that might look like, okay? We have our two top chambers there, our two bottom chambers. And they're all pumping simultaneously, right? So the top chambers are going to bring blood through the valves to the bottom chambers, and the bottom chambers are going to pump blood to our lungs and to the heart. And all of that is working all at once simultaneously in a very coordinated fashion. Run that video one more time. And you might ask, reasonably, how does the heart know to do all of this in a coordinated fashion, right? And so that comes down to the conduction system in the heart, which we'll talk about next, okay? If we look in our home, we have all of these appliances that require electricity. We have clocks, Wi-Fi, TVs, refrigerators, everything that requires electricity. And in the background is a very intricate system of circuits that delivers electricity to all of our different appliances. And so the heart has a very similar system. So here, again, is a picture of the heart, and then the yellow is the conduction system in our heart, okay? So conduction in our heart starts at the sinus node. The sinus node is the atrial pacemaker of our heart. It's our intrinsic pacemaker. So if my heart is beating 70, 80 beats a minute, that means my sinus node is firing at 80 beats per minute, okay? The electrical impulse then travels through both atrium and then down to what's called the AV node. The AV node is the connection, the electrical connection between the top chambers and the bottom chambers of the heart. The conduction then travels through what we call the bundle of His, and the names aren't super important, but then it travels to the bundle branches and then the Purkinje fibers, and these are individual fibers that deliver electricity to the muscle cells in the heart, okay? Our conduction system is made up of specialized heart muscle cells and fibers that carry this electrical conduction. So now if we put that on a beating heart, this is what it might look like. And you can see the conduction system in the background telling our hearts to beat in an organized manner. Why just stop? There we go. And then just to review, again, the sinus node, the AV node, the bundle branches, and the Purkinje fibers. And again, conduction comes down in a very organized manner. Okay, so now we'll talk about the specific structure of our heart muscle cells and what makes hearts with SADS conditions different. So I go back to my heart and the conduction system, and now I'm going to focus in on just the specific individual cells in the heart. And I think the video after mine will show some, as a video of the heart cells beating. This is a microscopic image of what our heart cells look like. And I don't think you can see my cursor. But cells, so each of the purple dots are nuclei. So each of the purple dots delineate the center of a cell. The lines that you see through are what are dividing cells. So the cells are kind of long, thin strands, okay? These are heart muscle cells. And if we zoom in between the cells, this is an even closer look at what the cells look like. So the line going through the middle of the page is the division between the two cells. You have one cell on top and one cell on the bottom. And you can see these big structures in between the cells. If I just take a more animated picture here, again, big structures in between cells. These structures are what we call desmosomes. Desmosomes are like the skeleton of the heart muscle cells. The desmosomes are important for keeping our heart muscle cells together and holding them together. There's some genes you guys might have heard of that are involved in desmosomes, including the DSP gene and the PKP2 gene. And mutations in these genes lead to what we call arrhythmogenic cardiomyopathy, which is one of the SADS conditions. Now, if I zoom in closer, just at looking at the surface of the heart cell, okay, So here I'm looking at the surface of one of those heart cells. So here's the inside of the cell, the outside of the cell. In between is what we call the cell membrane. And on the cell membrane are thousands, even millions of what we call ion channels. These ion channels allow our heart cells to deliver different electrolytes and ions in and out of the cell. That includes sodium, potassium, calcium, and many, many others. Okay. So if we go back to the analogy of how electricity works in our home and then in our heart. So in our home, electrical current is generated by movement of electrons across the circuit. In our heart, electrical current is generated by movement of ions or electrolytes across ion channels in the heart. And so as you can imagine, genetic alterations in these ion channels is what leads to many of the other SADS conditions. So this is not an exhaustive list. But for example, if you have a mutation in the sodium channel, that causes long QT syndrome or Brugada syndrome. Mutations in potassium channels can cause long or short QT syndrome. And mutations in calcium channels can cause CPVT or Timothy syndrome. And then finally, just a couple videos of what happens to a SADS heart during a sudden cardiac arrest. So here again is our normal conduction system with a sinus node or SA node or AV node and the rest of the conduction system. This is what happens during normal heart rhythm. So again, there's a very coordinated contraction of the bottom chambers. You can see that the bottom two chambers are squeezing very effectively, and that's because there's a conduction system that tells the entire heart what to do. During a sudden cardiac arrest, instead of that coordinated conduction, we have parts of the bottom chambers that are beating very abnormally and erratically and rapidly. And we can see what that causes is a ventricular arrhythmia. And if you contrast that with a normal heart, you'll see a side-by-side here coming up. So again, a normal heart with normal conduction, the heart is beating very, in a very concordant manner, whereas in a patient suffering from cardiac arrest, the heart isn't able to squeeze blood to the rest of the body effectively. So some patients with SADS conditions have the defibrillator implanted or an ICD. And so this is what the defibrillator does. So here, again, you're in normal rhythm. The heart is beating normally and it's squeezing blood effectively to the rest of the body. The device has now detected arrhythmia. Detects the arrhythmia here and it shocks right there. There's delivery of shock. It resets the heart and brings it back into a normal rhythm. So just to play that again, normal rhythm, heart beating normally, heart pumping blood normally. Here's the arrhythmia, erratic rhythm coming from the bottom chambers of the heart. The heart cannot effectively squeeze blood to the rest of the body. The device detects it, it shocks, and resets the heart to a normal rhythm. An external defibrillator, so that's with a pad that you put on your chest, those do essentially the same thing. That's all I got. Thanks. Questions?
Any questions? Here. So from your defibrillator, the wire came down and it went through the atrium and then into the ventricular?
Correct.
So it goes through the valve?
Yes, the wire goes through the valve. In this specific type of defibrillator, which we call a transvenous defibrillator, the wire goes through the vein, through your right atrium, correct, through the valve between the atrium and the ventricle, and it lands in the ventricle.
And all, so that's that particular one, or are they all like that, or do they hit different parts of the heart?
Yeah, so the important part of a defibrillator is the shock coil is right here. And what you want is you want most of your heart to be between the shock coil and the battery. So here's the shock coil of this defibrillator. Here's the battery. And so when the device shocks, this is the vector of shock, and so you can see most of the heart is in between the two. So this is what a typical transvenous device looks like. Another type of device is the epicardial ICD. And so that is on the outside of the heart, but the same principle applies that you have a device here, a shock coil that's on the outside of the heart being between the two.
That's the right ventricle?
Typically, a transvenous device, correct, goes in the right ventricle.
Another question?
You mentioned, there was a slide that mentioned the sodium channels, the potassium channels. Could you talk a little more about that and how that relates to, you know, different conditions?
Yeah, absolutely. So all of these channels are encoded by our DNA. Okay, so our DNA kind of underlines all of the issues that go on. And the cell uses the DNA. There's machinery in the cells that use the DNA to create these channels. These channels are on the outside of our cells. Some of the channels are actually on the inside of our cells. And these cells are critical for our heart to function normally because it is the flow of electrons, the flow of ions. So electrons are charged particles that flow in circuitry. So ions or electrolytes are also charged particles. Sodium is a charged particle. Potassium and calcium, they're all charged particles. And in order to generate a current, you have to have movement of charged particles. It's a kind of a basic principle of electromagnetism. And so the flow of those charged particles through the channels in the heart is what generates the current of our conduction. When those channels aren't formed correctly, or there's defects in the channels, or the channels don't work correctly, that's when you have a condition that can predispose.
Any other questions? Here we go.
Hey, could you explain the difference in how the heart acts in VT versus sudden cardiac arrest? Does one lead to the other, or are they different heart dysfunctions?
Yeah, that's a good question. VT, or ventricular tachycardia, is the rhythm. Sudden cardiac arrest is kind of the presentation. Someone who's fainted, who doesn't have pulses, anything like that. There are many different rhythms that can cause sudden cardiac arrest. In patients with the SADS condition, the two most common causes are ventricular tachycardia or ventricular fibrillation. So those are the rhythms. Sudden cardiac arrest is the kind of what someone shows up.
I'm going to ask a question to get a little bit more specific on, can you tell me a little bit about LQT1 and potassium channels? In particular, is it that the potassium is moving slower or faster? Or
So LQT1 is caused by a specific potassium channel mutation. The specific gene is called, you know, the KCNQ1 gene. And it results in a loss of function in that gene. That gene is not functioning appropriately. And so the potassium channel is made up of many genes. Okay. KCNQ1 gene is only one gene of the whole potassium channel apparatus. But when that, in long QT type 1, that specific gene is not functioning, and that kind of takes down the whole apparatus and makes that whole apparatus not function as well. So as a loss of function, it means potassium can't flow through that channel as effectively as it should. One more question back there. Go for it.
Here you go. Okay, I get it anyway. So for many of our conditions, including mine, which is the arrhythmogenic cardiomyopathy, ablations are big. In terms of the electrical system, just briefly, can you talk about how the ablation impacts that electrical system in a positive way for these conditions, potentially?
Yeah, that's a good question. I will say ARVC, or arrhythmogenic cardiomyopathy, is a little on the unique side in the sense that ablation has been proposed as a potential, a lot of these conditions, actually, ablation there's really no indication for ablation. Like long QT syndrome or CPVT, there's not really any data that ablation helps. In ARVC specifically, as the heart muscle starts to weaken, parts of that heart muscle can fire abnormally. And so if we go to this video, this is just kind of a schematic of all these different parts in the heart that are firing abnormally. The purpose of an ablation is to target one of these spots and zap it or burn it to get rid of those cells. And that can potentially decrease your risk of having a arrhythmia. There are certain cases in rhythmogenic cardiomyopathy where an ablation might help, mainly if there's only one primary spot that's firing abnormally. However, in a lot of SADS conditions, what ends up happening is there's a bunch of different spots in the heart that fire abnormally. At that point, ablation is kind of like a whole lot of benefit, right?
Thank you. Here, I'll bring the mic to you.
Could you explain why the different flavors of these diseases have different triggers? So some things will be triggered by athletics, some will be triggered by startling, things like that. And then also, how does the medicines like beta blockers and mexiletine help prevent these things?
Yeah, it's a good question. In general, things that ramp up the adrenaline in our body are triggers for arrhythmias in these conditions. In terms of the specific differences, I don't have a great example of it. For example, long QT1, arrhythmias are typically triggered by exercise, classically due to textbook. In long QT2, it's triggered by like a startle, like in the long textbook. Kind of the end common pathway of both of those is that your adrenaline level gets ramped up really quickly. And that is what is the trigger ultimately for the arrhythmia. Beta blockers, which are the most common prescribed medication for these conditions, beta blocker just means it's medicine that kind of blunts the effect of adrenaline in your body. It prevents adrenaline from acting as forcefully as it could. And that's why beta blockers are commonly prescribed here.
Okay, thank you very much, Dr. Hong. We appreciate your help. Okay, now I'd like to invite our Northwestern University lab techs you're from Beth McNally's lab, right? Okay. So they're going to make a little presentation and then also have a video to share. I'll cue up the video while you start.
Hi, my name is Ivana, and this is Augie. We work in Beth McNally's lab at the Northwestern Feinberg School of Medicine. Our lab studies the genetic modifiers of cardiomyopathy, and wanted to share a little bit with you today about what we do. So the history of, we mainly work with engineered heart tissues. The history of tissue engineering goes back to like the 1950s, but in the 1990s, in the 1990s, the first engineered heart tissues were made from embryonic chick cells. In 2006, the Yamanaka and Takahashi work with factors that can turn body cells into stem cells. That was done, and later on, the first cardiac cells were made from these induced stem cells. Our lab has been working with these cells for a few years now, and show you how we make them.
So Ivana kind of touched on what an EHT is, but to kind of give you a little more in-depth sense of what it is, what we're able to do now is we're able to take cells from your blood or even urine, and we're able to turn them into induced stem cells. And so previously we could work with embryonic stem cells, but now we're able to take certain cells, almost undifferentiate them, and then we're able to differentiate them down a different pathway and turn them into heart cells. So essentially what we're doing is we're turning urine or blood into heart cells that we're then able to turn into tissues, and we can
have both healthy tissues and unhealthy tissues, and that way we're able to see how a disease can progress outside of the body in an in vitro model, and we're also able to test particular drugs on it. So to kind of give you a sense of what this actually looks like, what you see on the screen right now are induced pluripotent stem cells that are in a dish. And so these are cells that we got from the blood, and then we took them up a level. And so now they're kind of like the cells that you would have in an embryo that can turn into any cell in the body. And with a couple factors, we're able to then turn them into beating heart cells. So we're able to have these beating heart cells in a dish. And so just a moment to admire the video because it's the coolest thing ever. But to give you a little close-up video of what that looks like, you can see how vigorously they're beating and how kind of like how Dr. Hong was touching on, how those cells form those little connections between them. And those are often where the desmosomes are often the site of a lot of diseases that we look at. One thing that's particularly cool is that we're actually able to differentiate cells into both atrial and ventricular cells. We can also differentiate cells into fibroblasts, immune cells like macrophages, put them all together and test different things. And so, for example, if you have a disease that really looks at fibrosis in the heart, we can really play up those diseases in the fibroblasts and see how those impact the tissues. And one of the really cool things here is you can see how the cells actually beat differently. And I have not actually had the joy of making atrial cells yet. But Ivana, correct me if I'm wrong, but I think it's actually just one additional thing that turns a ventricular cell into an atrial cell. And so it's retinoic acid, which is just vitamin A. So it's very, very cool and impressive that the body works like that.
So what we end up doing with these heart cells is we combine them with cardiac fibroblasts, human cardiac fibroblasts, and we put them into a tissue form. And so after we culture them, we're able to make measurements on their forces, their electrical activity, and hopefully the video plays, but you can even visually see differences between the tissues made from healthy individual-derived cells and patient-derived cells. We were working a lot with DMD patient cells, but we have also moved on to other more arrhythmia-related diseases like a laminin mutation. Yes? Yes.
Oh, sorry. Essentially, the point that we were trying to make here, they beat, it might be a little hard to see, but with the healthy cells, you can see them beat a lot more vigorously, a lot more uniformly, and then with our diseased heart cells, you're able to actually see that that is not the case. And so they don't beat as much, and they don't beat as uniformly. Unfortunately, the video is not working. Sorry. Yes, please.
How was everyone's day so far? Yes? we just had a question about whether the induced cells are the same as native cells. So unfortunately, no. When we induce them into stem cells and send them down the pathway, the current state of the research has only really been able to generate neonatal-like or fetal-like cells. So that's actually something that people are working on right now, is how to mature the tissues past the point of like a neonatal cell. But there's different things that we can do. Like we've actually found that pacing them, stimulating them with electricity or stimulating them with force, or adding other cells like immune cells and fibroblasts can actually make the cells mature. But it's like they say, no model is perfect, but some are useful. So I wanted to also share some of the work that our lab has been doing recently. There was a big collaboration between multiple labs at Northwestern, between cardiologists, scientists, engineers. We developed a device to measure engineered heart tissues in a non-invasive and non-terminal way. A lot of the times when you generate tissues and you're measuring the electrical ability of the tissue or the contraction, you have to use compounds so that the tissue stops beating, so that you can actually see the conduction in the tissue. But our device, because it has multiple points, allows us to make measurements over time, so we can actually see how the tissue strength develops over a period of weeks. We can test different drugs. We can test, we can actually induce arrhythmias into the tissues, which is really helpful in testing like treatments. Yeah, you can kind of see, hopefully, beating. It looks like it's actually in an arrhythmic cycle. Yeah, there's a lot of work currently being done to make these models better and find treatments that would help. Yes? Sure. Just had a question about the outlook, the future, what potential treatments are going to look like. I think gene therapy is very early on in its stages. Something that we are particularly interested in is the cardiotoxicity, because when we have used models with mice or different animals in the past, the treatments might be effective, but when transferring that to a human clinical trial, there are times where these medications are actually harmful. And by using patient cells, we are able to kind of see if that medication would be safe for human use a little bit better.
I just want to add a quick point to that. You mentioned gene therapy. So for some of these diseases, what we are looking for is figuring out ways that we can have those sorts of gene therapy. And they aren't necessarily things that have to go in at an early stage or at birth. And so I know recently there's been like a clinical trial for gene therapy for PKP2, one of the mutations in a gene that can cause ARVC. One thing that we are actually currently studying in the lab is ways that we can leverage gene therapy. So this is not editing the gene, but changing the way that the body reads the gene and how much of the gene it reads to actually help remediate some of the things with DSP mutations, so some of the other mutations that can cause some of these arrhythmic diseases. But hold on. Oh, one of the things that we actually wanted to talk about was where this all heads, which is where you were so mindfully pointing already. And one of the things that we really plan to use EHTs for is for modeling the disease for drug testing. And so the FDA recently got reauthorized with a new modernization act, and for the first time, drugs don't have to be tested in animal models. And so there's a hope that we can really leverage some of these more patient-specific models to test how exactly it's going to behave in an individual person, and not only on like a one-by-one basis, but to have really high throughput screening, because you can just test a bunch of different drugs, like maybe 96 drugs in the 96-well plate. And I think the other thing that I would probably mention that's really cool about this kind of work is that you've kind of heard me allude to it, but these are patient-specific. And so when we think about a future where we have personalized medicine, where we're able to predict and prevent illness in an individual, these cells are very, like, they're that patient cells that we have in that dish. And so we can test how an individual person is going to respond to a particular drug. And that's really important because all of these diseases, while they might be caused by similar mutations, might manifest differently in individual people. And so this is actually like very, very personal to me. I lost my brother last September to sudden cardiac death. And so that was one of the reasons I wanted to join this lab, is because they're really working on a paradigm that will help shift medicine into a more like preventive, proactive sort of future. And so Justin, my brother, he had a couple things that were wrong with his heart that we only found out after the fact. And so you could actually model that here, where you're not just studying one mutation, but you can have a person who has those specific couple mutations that might be wrong or abnormal in a heart, and you're able to see how a drug might respond there, how a gene therapy might respond there, or at the very least, kind of discover how those mechanisms interact to produce the disease that you see. And so that's kind of where we think this is heading and why we think it's really, really cool. I think that's all we really had for today, so if there's any questions, happy to answer. Otherwise, we could also happily go back to the videos and look back at beating heart cells.
Hi, thank you. That was fascinating. I'm sitting in like the ARVC corner over here, and we were actually talking before this about different medication issues we have. I'm personally gene elusive. Would that kind of personalized, patient-focused trial work on gene elusive patients, or is it just those?
Gene what patients, sorry?
Gene elusive.
So I think we're maybe not as knowledgeable about this, but I think having a platform to test tissues, you would have an opportunity to not just test, gene editing or, AAVs or something like more gene therapy. You would be able to see if different compounds would have a positive effect on the function of the heart cells. So it wouldn't necessarily have to be related to genetics. It could just be the function of the cells and seeing like what compounds could help. So potentially, yes, I think.
Any other questions? Well, thank you very much, Augie and Ivana. Appreciate it. I'm waiting for my next speaker to come in. Yeah, we just found him. Want to take a stand-up stretch break? Stand up, everybody. Go on, stretch. We could go with Stu. Do you want to go ahead and do yours first? And that'd be great. We're still tracking down Peter and, okay.
Okay, good.
All right, let's have a seat and we'll get started. Dr. Stuart Berger is going to talk about tips on CPR and owning and caring for your AED, an electrophysiologist and chief of cardiology, right, here at Lurie Children's Hospital. Everybody grab your seat. We'll get
Thank you, Marcia, and we go back a long ways. I won't say how long, but it's an
back
honor.
to my American Heart Association.
Yes, for sure. It's an honor to work with you with SADS and the AHA, and thank you for all that you do. And obviously, thank you for all that SADS does. Alice and I go a long way, which means that I'm old, I think. But thank you all for being here. And I ultimately want this to be an interactive discussion. I'm going to start out with showing some slides about some of the things that we do, which will ultimately lead into the discussion about CPR and how to care for your AED. And I think I'd like to make this talk a bit more generic, but and then you can certainly add to what I'm going to talk about, and I'd love your opinions on this. And I think the way I wanted to start this is to talk a little bit about a project that I've been involved with now for the last 25 years. This is not meant to be a shameless promotion of Project Adam, but I want to tell you a little bit about Project Adam. I think many of you know about it, and the humble beginnings where from which this started, again, 25 years ago, and then maybe relate to some of the things that you're interested in, and I'd love your opinion on this stuff. This goes all the way back, Project Adam, and my interest in sudden cardiac arrest, 25 years ago to January of 1999. Pete, if I'm taking your time and you want to go, you're okay? All right, good, thanks. And the acronym ADAM, after which Project Adam was named, after this young man, Adam Lemmel, stands for Automated Defibrillators in Adam's Memory. So the story of Adam goes to January of 1999, and I was working in Milwaukee at the time at Children's Hospital of Wisconsin. Adam was a 17-year-old young man, high school basketball player, and played a game in the suburb of Milwaukee at a place called Grafton, which is a high school a little bit north of Milwaukee. And he collapsed during the basketball game. It was a Friday night. Sadly, I remember it like it was yesterday. CPR was begun as he collapsed, and people recognized that he did not have a pulse. There wasn't an AED at the site. Again, 25 years ago, the concept of school AEDs and school CPR programs was pretty unusual, sadly. And interestingly, there was a firehouse right across the street, the Grafton Fire Department, but it still took, even though it was right across the street, it took 10 minutes to get there. 10 minutes for the paramedics to, by the time they got called, they came to the school, they came to the front of the school, they had to get to the gym. So you would think across the street would be a piece of cake, they would be there in a minute, but it was 10 minutes. And Adam didn't survive. As it turned out, Adam had a condition not known before his death that many of you have heard of and are familiar with, I think, called right ventricular dysplasia, arrhythmogenic right ventricular dysplasia, or right ventricular cardiomyopathy. And of course, we didn't know that because what was Adam's first symptom? This. Totally asymptomatic before that. And I got to, this was Adam. Obviously, I never met Adam, but I got to know Adam. I got to know his father, and I got to know his mother. Because the other thing I would tell you is that, before I get to Matthew, that happened in January of 1999, and over a period of about 11 months, we had four more, I should say, incidents of sudden cardiac death, sudden cardiac arrest in the Milwaukee area. If any of you are familiar with Milwaukee, it's about 90 miles north of here. It's not a big city. It's not a small city either, but 5 episodes of sudden cardiac death, sudden cardiac arrest was kind of bizarre, but this is what we do. I'm a pediatric cardiologist, and if there is going to be a referral, whether it's to work up a family or work up a child, they're going to come to us. And I think if in my mind, going through the diagnoses, not all of the kids died. 3 of the kids died, 2 of the kids survived. Adam had RV dysplasia. One of the patients who did not survive had hypertrophic cardiomyopathy. Another one who did not survive had an anomalous coronary artery, a left coronary artery from the right sinus of Valsalva. And the 2 kids who did survive, one of them was a young girl who had also a left coronary from the right sinus of Valsalva, but she got CPR and was able to be resuscitated. And the other one who survived was a young man from Manitowoc who had long QT syndrome. So you know these diagnoses. You live and you breathe these. You heard about them this morning. They're known diagnoses, but in that short period of time, 5 kids. Now let me jump ahead to another story. I think many of you have heard this story. This is a story of Matthew Mangine. This is now 21 years going forward. And Matthew, to tell you that story, 16-year-old, it's almost like a recurrent theme, and I know many of you have lived this and probably have similar stories. Lived in northern Kentucky, not that far from Cincinnati, but across the border. In June of 2020, he collapsed during soccer practice. I think it was in June. It was very hot, but he collapsed. They had, as I remember and as I recall, and many of you may know the story better than I, 4 AEDs at the school where he collapsed, but none of them were used. They didn't know about them or they didn't pay attention to them. And even though a school emergency action plan, and we're going to get to talking about that in a little bit, maybe different than the scope of the title of this talk, but I want to get to that. It stated they existed, but an AED was not used. Again, let me emphasize, they had 4 of them there. An AED was not used until the paramedics got there, and sadly, Matthew did not survive either. The picture of Matthew, and I've gotten to know his parents, who have now become very involved with CPR AED education, advocacy, and in fact, I think there is an ESPN or a 30 for 30. I don't know if you're familiar with the 30 for 30 ESPN films. Not based on Matthew, but telling the story of Matthew, of what had happened to him, and I think how we have to prevent what happened to him and going forward. So let me tell you a little bit about Project Adam. It is a little bit of a shameless plug here, and I'll tell you why that is. Again, automated defibrillators and Adam's memory. It was an initiative that was started back in 1999. With 3 goals in mind, and those 3 goals are to prevent sudden cardiac arrest, sudden cardiac death, and I'll get to more of those details in a little bit. But it began about 11 months after Adam's death, and it's more than just a school CPR AED program. It was really created to prevent all of what you just heard, to prevent the Adam Lemmels and the other kids in Milwaukee, the other kids in the world, the Matthew Mangines, to prevent all of what you had just heard. And the goals back in 1999, which, by the way, are no different than the goals right now, in 25 years later, was education. Back in 1999, the concept of sudden cardiac death, sudden cardiac arrest in kids was unheard of. I think that we heard about that a little bit this morning at Dr. Baer's grand rounds, and what Dr. Ackerman said, nobody knew about it. Or nobody believed that it was a real thing. They thought it was a fluke, but it's not a fluke. You all know that. You're here and you know that. It's not a fluke. So letting people know that this is a real thing, knowing that there are warning signs, that family history is important, that screening is important. Again, this is not something I have to tell this audience. You know this better than I do. So the education was critical. We believed then, and we believe now, that all students should learn CPR and how to use an AED before they graduate from high school. We'll talk about where we've gone with that because I think there's been really some good things with advocacy. We believe, I got to change the slide, I keep forgetting to do that CPR AED programs should be in all high schools, not in the state of Wisconsin, but in the United States, in the world. Tell you about some of the other things we're thinking about in the world, but everywhere. And we believe, and probably more strongly now than ever, that cardiac emergency response plans have to exist for all schools. And not only have to exist, but you got to talk about it, you got to review it. All schools should have drills. There was a cardiac emergency response plan in northern Kentucky, but nobody looked at it. Nobody paid attention to it, and they had 4 AEDs there. So not only do you have to generate that, but you have to review it, and you have to pay attention to it, and you have to do drills. And by the way, I'll take this one step further in that we believe that all of these things can be legislated, and part of the legislation is that it allows for an advocacy and awareness. If you go to whatever state you're from and you get in front of the state legislature, as I bet many of you have done, you can make the state legislators understand this. They won't fund it, but we've always figured out a way around that. If you can get the state of Illinois, for example, to understand the importance of all students learning CPR and AED use, we'll figure out a way to make it happen through the American Heart Association, through Project Adam. And that's important because those students who grow up to be adults, if someone's walking out here along Chicago Avenue and has a cardiac arrest, they'll know what to do. And they'll hopefully intervene by recognizing it. So these are all important legislative things that may not be funded, but we can make it happen. And all four of those are important. And again, I suspect that many of you have been involved in your state making this happen. So since we started Project Adam back in 1999, as you can imagine, it started in Wisconsin with a little bit of discord, if you will, and some people who absolutely told us that we're out of our minds, we're crazy. And actually, some of my partners as pediatric cardiologists told me that because, again, they said, kids don't have cardiac arrest. We know differently. I'm serious. They said kids do not have a cardiac arrest. And why would a defibrillator ever be helpful in a child or an adolescent? Because if they have a problem, it's either a respiratory arrest, and they certainly don't get ventricular fibrillation. We know differently, don't we? That's all a bunch, can't say the word, but it's all a bunch of BS. But back 25 years ago, and I hope many less people now believe that, people did not believe that was a possibility. And so over the years, in the 25 years, now we have 45 programs, I should say, in 33 states. We'd like to actually get programs in all 50 states. I think I might have a map, so you may know if your state is part of this or not. And although those doubters said it's not going to make a difference, in those 25 years, there have been 300 saves from sudden cardiac arrest in schools. They're not all kids, as you can imagine. There's adults in schools, there's teachers, there's parents who come to sporting events or plays or musical events. So about 60% of that 300 have been adults, and about 40% have been kids. So that's 180 adult lives saved, and that's 120 pediatric lives saved. It's over 25 years, but I never in a million years thought we would get to those numbers. And again, I can tell you that it was because of the people who believed in this and really thought, we've seen this in our area, we've seen it in Cincinnati, we've seen it in Ohio, you name wherever. And people have also felt we've got to do something, and they did something. And I'm so thankful to all of my colleagues for that. So here's the map. The red states aren't what you think. Probably shouldn't have even said that. Here's the map of where the states are that have programs. Some of the stars show places that are in progress right now. We're talking with our colleagues in Alaska. Susan Etheridge is thinking about project in Idaho. Susan is now in Idaho. And we'd like to get 50 states only because we would like to have representation across the country. The interesting part, and again, I think the important part, is that almost all of the programs in all of the states are based at a children's hospital. And I think there's a rationale for that. The pediatric EP folks tend to be aware of the issues. When kids and families get referred, those are the places that they get referred. I don't think it's an absolute necessary requirement, but it turns out that's mostly the case. And most of the people in the next room and who you have seen here are very involved with Project Adam and are members of Project Adam. So if your state is not up there and you have an interest in helping us advocate, again, I'm not making this a shameless self-promotion, because it's not self-promotion. This is something that obviously we put in place to save lives, and I think is a real opportunity for families to be advocates and help us with this. And in all the states, there are families, local families, who are part of this, and even families who are part of programs in other states. I am very interested in expanding beyond the United States, and we have a couple of programs in Canada. I don't think it shows up on there, but we have some interest in Canada. And actually, I've had some inquiries in the United Kingdom, and I've had some chats with Elijah. The healthcare system there and the children's hospital system in the UK is very different. But on the other hand, the advocacy for doing these things goes beyond the borders of the United States. It's something that we really should think about long range and everywhere. If you couldn't quite see the children's hospitals, these are the logos of all the children's hospitals, and I'm sure many of them in your neighborhood, in your area, are represented or could be represented. Here's a few more. We spill over to a second slide now, which is a wonderful thing. I want to emphasize this, and again, I know that I am preaching to the converted, and I'll show you why, and I think many of you will understand why, not only from personal experience, but the CERPs, or the Cardiac Emergency Response Plans, are critical. The American Heart Association has helped us put this together, and practice, 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 and drill are important. You can imagine that any individual school, you may never see a cardiac arrest, or if you do, it could be once in a lifetime. So you might not expect that every school is going to know exactly what to do, because God forbid it happens in your school. But if it does, you need to know. So the practice and the drills, which are part of a cardiac emergency response plan, and which we recommend, along with the Heart Association, to really do probably every 3 months. You do fire drills, and you can tell by my age that what I'm about to say is an age thing. We used to do air raid drills when I was in. Anybody remember that? All right, I'm sorry I asked. And you know, I guess I shouldn't jest about it, but then, you know, at the time, the nuclear attack by the Russians was probably not very common. I hope it's not a problem right now. We don't do air raid drills anymore. I remember getting down under a desk and putting my hands over my head. Remember that? And I guess if an atomic bomb was coming, putting my hands over my head probably wouldn't have. In any case, these are real drills and are really very important to do, and I think are a critical part of going forward and being prepared. Anybody know who this is? Anyone? Damar Hamlin. What happened to him was a prototypic example of being prepared and what being prepared does. And as you remember, on January 2nd, 2023, anybody watching the game when it happened? January 2nd, 2023, 25 million people watched. You couldn't actually see them doing CPR. You couldn't actually see them using the AED, but they did. And maybe you don't know this, but I'm going to say it. Before every National Football League game in every city, they practice CPR drills. They practice for what they would do if somebody had a head injury, had a concussion, and they practice what they would do if somebody had a cardiac arrest. And so that night in Cincinnati, they had practiced this, and when Damar went down, and he probably had commotio cordis, which is a sudden cardiac arrest after a blow to the chest. They were ready for it, and they sprung into action. And you know what happened? He survived, and he's back playing again. I think he had his second interception a couple weeks ago, and he's back playing and playing well. So that concept of being prepared was witnessed by 25 million people a little over a year ago, a year and a half ago. And as another prototypic example for being how you need to be prepared, and as many of you know, the National Football League has taken that very seriously and has been involved with advocating for CPR AEDs, for actually putting together and supporting a federal bill which would allow for AED placement in schools. So I don't want to say that I'm happy with what happened with Damar. Obviously, I'm happy with the outcome, but what did happen to him, you know, has raised an awareness. And by the way, he is very involved. He and his family are very involved with advocating for CPR and AEDs. And actually, he's visited here, Jacqueline, what, about 3-4 months ago? He visited one of the kids in the hospital who was waiting for a heart transplant. And Damar's an amazing young man, as is his mom and dad. So he is really helping the cause. Now, you could ask the question, and I think it's fair enough to ask, and I hope you have seen from the data thus far that doing what we do, and you're all part of this, whether you know it or not, makes a difference. But is there real data to suggest it makes a difference? One of our dear friends and colleagues, John Dresner, who is a family practice doc, sports medicine doc, and also very involved and interested in the area of sudden cardiac arrest, did a study. It was a few years ago, but he looked at schools. He did a 2-year prospective study looking at schools that had CPR AED programs. And he has a registry that looks at this very carefully. And between 2009, 2011, it was a while ago, it was a few years ago, he looked at over 2,000 schools that had CPR AED programs. And what John found was amazing data. I'm going to ask you a question after I show you this data. But what he found is that if you had a cardiac arrest in a school, adult or child, and you'll see the data based on age, adult and child, you had a overall 72% chance of survival because of practice and because of early involvement, early intervention. And if you were an adult or a student athlete who had a witnessed cardiac arrest, looking all the way over on your right, you had a 90%, almost 90% chance of survival. And in this study, the incidence of CPR, that is to say the incidence of people who had a sudden cardiac arrest who got CPR was almost 92%. What do you think the incidence of CPR is if you just happen to be walking down Chicago Avenue or name any street in your city? What would you think the incidence of bystander CPR is? Any guesses? Say 10%, did you say? 10 to 20%. It's really low. If you live in Seattle, it's a little higher. It's about 40% because of advocacy and a lot of work they've done. If you live on the west side of Chicago, it's 0.5%. It's really low. I think it's a little better now, but when the study was first done, it's really low. In this place, in this study, in schools, 92%. What do you think the overall outcome of out-of-hospital cardiac arrest is across the board for everybody, just in general? You probably know this, but take a guess. High, low, or medium? Low. 10 to 20%, not much more than that. It may be a little better now. It may vary between cities, and that's because the incidence of CPR is so low. But take a look at this, 90% survival in schools in certain situations with a 92% incidence of CPR. So the question is, can we reproduce that on Chicago Avenue or on the west side of Chicago or wherever you might be? And I think this is a perfect example. It does make a difference. School CPR programs make a difference. It saves lives. But we need to extend that everywhere. We need to extend that to athletic fields. And actually, John Dresner is very involved now with a project to extend CPR, but to extend AED placement in athletic fields. And actually, in Seattle, I actually talked to John today. We're on a call for another purpose. They've now started putting CPR on street corners in Seattle. So you can go to Starbucks and get a cup of coffee in Seattle, and then outside of Starbucks there are AEDs. That's a joke, but they really do have AEDs in the city, and I think this could be a thing of going forward. Obviously, we're talking about home AEDs, and I suspect many people in this room have home AEDs, and that was one of the titles of this topic. But I think we're going to be finding out that AEDs will be placed in cities, and obviously it has to be coordinated so they don't get stolen. But I think that's a thing of the future, and I think, again, as often is the case, Seattle has become the prototypic community to make that happen. I showed you the numbers there. I think I'm going to stop here because, again, I wanted to give the audience a chance to chat. And I think one of the questions or one of the issues or the titles of this talk was CPR and being prepared, and how do you make sure your home AED is prepared. I think the key is prepared. I think you can't get an AED, put it in the closet, and just leave it there and expect that it's always going to work. I think just as with a school cardiac emergency response plan, you've got to check the batteries, you've got to check the pads, and I think the preparedness and the drills and making sure that you're aware of checking things often. And in terms of CPR, having CPR education and re-education, hopefully none of you will ever have to use CPR, but if you do, being educated and being re-educated is important. I think, Marcia, I'll stop there. I don't know that I exactly covered everything you had in mind, but I think a big key to this is audience participation, and let me know what you think. And if you have any comments or additions to the stuff that I talked about. Jacqueline is here, and Jacqueline is our Project Adam, wonderful Project Adam coordinator in Illinois. And I don't know if, yes, she does deserve a round of applause. I don't know if you wanted to add anything to that, or I'll bring the mic to you if you do.
Let's give Dr. Stuart Berger a round of applause.
Oh, it's my honor, truly my honor.
Yes. No, I think you got a lot of it covered. Just pertaining to AEDs and your AEDs at home, if you're having trouble navigating, like, how do I maintain my AED? Like, contact your local Project Adam team as well, too. Even though we focus on schools, communities, and youth sports teams, we're willing to help families as well, too. So if you're having trouble navigating, how do I get an AED for my own home and for my own family and such like that? Our Project Adam sites are definitely more than happy to help families out as well, too.
So I saw on the list our home children's hospital is involved with Project Adam, but one of the issues that we're facing is that we can't get our largest public school system in the city to jump on board. So what are your suggestions as far as advocacy as parents as how we can help push that forward? I know the hospital's working on it, but how can we help support them?
Not a unique problem. Can I ask what city? You don't have. There's a. You know Allie Black? Yeah. I think you just have to. Probably have done that already, or. I think if you get. Tell them the stories happened, in North. I'm glad that Allie's got all the information I was going to say. You have to be persistent. We had the same problem in Milwaukee. You sort of have to be a thorn in their side. But I think being advocate and Probably getting all the arguments we can't afford it. I think we just keep plugging. God forbid you would ever have an Ohio everywhere where I think if we plugging away and showing them.
Okay, thank you very much, Dr. Berger. I'm going to introduce our next presenter. She has an international flight. Okay. Dr. Beth Stephenson is from the University of Toronto, where she is a professor, and pediatric EP, and traveled down to talk to the healthcare professionals next door, and then she shared about participating in research.
Thanks very much. Excellent. Sorry, a little technical difficulties, but we're good to go now. It's really a pleasure to be here, and to give you a little bit of background. I am a student in my day job, but I'm also the chair of the Katherine Hospital, very, very large children's hospital, and so I'm deeply embedded in the research world, which is my and speak a little bit about research more generally, particularly as research opportunities are really starting to grow in this population. I see someone doing this. Can you guys hear me okay? I don't know what else to do. Is that better? I have to be like a rock star. Okay, I've told it really high. Excellent. So we're going to talk a little bit about research in general, and kind of what are the questions you might want to be asking, what do you need to know? So there are a ton of different kinds of medical research. We talk about epidemiological research, which looks at disease in population. Behavioral, which is all about psychological research or human behavior. Health services research is a lot about how you pay for health care. And the basic science research, which is the lab stuff, usually looking at things at a cellular level. But what we're really going to focus on today are clinical trials studying the effects of an intervention in a specific healthcare outcome, as well as observational. Also look at a single disease process, but without any intervention. So observational research has a variety of different categories in it, and it may or may not require you as a research participant to know that it's going on. So this includes traditional health chart research, where go back and look at 150 kids who all have effects over the last 20 years and try to see how the disease progressed and what we did that worked, what we did that didn't work. It would also include things like questionnaire-based research or imaging research. None of those include any kind of intervention. For all of those, there may be what's called a waiver of consent. So the ethics review here in the United States is called Institutional Review Board, or IRB. In the UK and Europe, it's called the Ethics Committee. In Canada, we call it the Research Ethics Board. We all do the exact same thing. We provide independent review of research projects, and we have the ability to waive consent. And that means we say it's okay not to ask each and every person to look at their medical records for this. We have a lot of very specific considerations that we take into mind before we grant this, particularly around privacy protection, which is really the biggest. Now, clinical trials are the thing that I think a lot of you guys may be starting to think about or hear more about. The clinical trial typically involves some form of intervention, whether it is a new drug, a new surgical intervention, a new combination of drugs, a medical device like a new kind of pacemaker or ICD, or even just a new way to use an existing treatment. There are also ways to do behavioral interventions where you try to teach somebody who you have to take better care of themselves. All of these are aimed at learning more about a disease and learning more about treating a disease, usually about a specific response to treatment. So when you talk about clinical trials, you'll hear people talk about the different phases of research. So a phase 1 trial is looking at safety and to identify side effects. It's typically done in a very small number of participants, and it is not intended to provide benefits. That's a really important thing to recognize about a phase 1 trial. Now, a phase 2 trial expands the number of people, and it is the first trial that starts to look at whether or not the intervention actually works. Does it help make people better? Does it help to treat the disease? It also looks very extensively at safety, and it can often be used for what's called dose finding. So trying to figure out how much of a given medication you need to give somebody in order to start to see those effects. Phase 3 trials, again, the numbers go up, and we're really looking more specifically at the details of effectiveness, often at the subpopulation. Does it work in this kind of patient with disease X, but not this kind of patient with disease X? Also looking more carefully at side effects, especially the rare ones. You may not start to see those until you're testing it in a larger population. And then very frequently, you're starting to compare whatever your intervention is with standard or similar treatment. And then a phase 4 trial is what's called also a post-marketing trial. So this is something that has been approved here by the FDA. It's available to be prescribed, to be used, but there's often a lot more that we still need to learn about this. And sometimes you hear about drugs that are withdrawn. You probably remember Vioxx was an arthritis medication. It's very, very popular and very, very effective. And it wasn't until it was marketed and used in hundreds and hundreds of thousands of people that they realized that it caused heart attacks. The problem, and it's been pulled off the market. And so the phase 4 trials can be really helpful to track safety, especially long-term side effects that don't show up in clinical trials, which are, at best a few years. Okay? So why participate, right? Why would you want to do that? It can be a lot of work, and it does involve some risk, but it also potentially involves some benefits. And the reason that any given individual might decide to participate it is going to be different. So one of the things is pure altruism, right? You're going to help advance science. You're going to help the treatment of a given condition, right? So there is a lot of altruism in participating in research. You may help others who have the same condition, or you might actually volunteer as what's called a healthy control. So you don't have the disease, but you can be a comparator population, which is really helpful as well. You may have early access to treatment that is better than what's available standardly, but you may have access to an ineffective or risky treatment. So you really have to think carefully about that. You're going to learn more about your own condition, and you're going to learn more about its treatment because you're going to be deeply embedded in the world of that clinical trial. And you do have the opportunity at times to be part of a community to be really valuable, especially for people with more rare disease. So how do we try to make sure that this is as safe as possible for all of the participants? So that is the job of the ethics board. Our primary goal is to protect the participants. So when we do our ethics review, we look at every single clinical trial that's going to happen within our boundaries, which is usually within our hospital. And we want to make sure that the appropriate steps are being taken to protect the rights and the welfare of the participants. The other piece is the regulatory review. So for any kind of large-scale drug trial or intervention trial that's going to require FDA approval, there are very strict regulatory guidelines that they have to adhere to during the trial to make sure that the participants are protected, but also to make sure that the science is good so that the conclusions at the end are actually correct. When you show your drug works, you better be testing it properly. So when we look at the ethics of a clinical trial, we have kind of these 7 major categories that we evaluate any medical research on, and actually any human subject research at all. I'm not going to be able to have time to kind of go through all of these, but respect for participants is making sure that people are being treated with the decent human respect that everyone should give, and this also includes respecting someone's privacy. Value and scientific validity really go hand in hand. The research has to have some meaning. It has to contribute to the well-being of society or the individuals who are participating, and it has to be scientifically valid. So what you get to at the end has to actually be true, has to be real. And this is because, unfortunately, there has always been and will always be in medicine a fair amount of quackery and people who propose snake oil. You know, that's the real thing. And so you want to make sure that you're picking things that are good and real. Fair subject selection is about making sure that everyone has access to research opportunities, and also that the research is done in a population that's actually going to potentially benefit from that. So you have to make sure that you're not offering all the benefits to one portion of society and all of the risk to a different portion of society. One of the classic things about this is children. Children traditionally were often excluded from research after pregnant women. And what we found is that over years and years and years, we didn't know whether or not these drugs would work in kids. We didn't know whether or not these drugs would be safe in a pregnant woman. And so there has been, over the last 20 years, a much stronger push to make sure that you're including all of these populations, and it should be across both disease groups, racial groups, ages. All of those things matter so that you know whether or not the risks and benefits actually carry across all of those. Independent review is all about having something like an ethics board that has the ability to review and approve or amend, as we say, or make changes to a project to make sure it's safe. And it has to be people who aren't funding the research, aren't benefit from the research, aren't benefit from the products being sold, and also independent from the hospital, because hospitals make money and get payments through these kinds of research trials. So people need to have a degree of independence. The 2, however, most important principles are the risk-benefit ratio and informed consent. I'm going to dive into those a little bit. So informed consent is critical not just for research, but for all medical decisions. And this is that any individual making a health decision needs to be informed about that decision, in this case, the research, and they need to provide their voluntary consent. And what the voluntary consent means, not just that you're agreeing to it, but you actually understand exactly what it is you're agreeing to. And in order to understand, you have to have the ability to understand. We call that the passage. And then you have to have enough information provided that you can make that decision. Now, not everybody has the capacity to be consenting to research, and as a pediatrician, most common example is kids. They may not understand the complex clinical trials, and in that case, you can put in a substitute decision maker, which is most commonly the parent, although not always, and that person will provide consent of the participants to the best of the abilities that they can give. And with this, that means that changes over time. You might have somebody that enrolled in a trial at 10, and their parents enrolled them and consented for them. That trial's gone on for 4 years. Well, they're 14 now. They actually really understand what's going on. You need to go back to those kids and make sure, hey, your parents signed you up for this. Are you still cool with this? And do you understand what's going on? Favorable risk-benefit ratio is the other really critical thing that we look at. And this is simple as it sounds. You need to make sure that risks across the board in the research have been minimized and any potential benefits have been enhanced. And overall, you have to have at least an even keel on these, and ideally more potential benefits than this. Now, the benefit doesn't necessarily need to be only to the participants. Sometimes, through altruism, the benefit really goes to society as a whole or the disease population as a whole, but it still has to outweigh the risk. So when we look at risk-benefit, it's not an absolute. I'm never going to say that risk is too much, no matter what. We can't do that. Because a potentially life-threatening therapy may carry some really dangerous side effects, but it's worth it, right? You think about, for example, our chemotherapy trial, where there's no good treatment for this cancer. There's a brand new drug. It's scary. It has bad side effects. But you know what? This person is going to die from their cancer. So we're going to take the risk. We're going to accept the possibility of these side effects because we finally have the potential of treatment. So it's very graded. And I would never accept that kind of side effect in a treatment, right? Like, you have to really balance that. So when we look at a clinical trial, how do we decide even who can be in the clinical trial? Well, this is decided by what's called the inclusion and the exclusion criteria. And those are built extremely carefully by the people who design and write the trial to try to minimize the risk and maximize the benefits of the efficacy. But they're also very, very commonly written to maximize effect. These are people who are trying to prove that something works, usually for a profit. And so they're going to try to pick the population that has what we call the greatest effect size. That doesn't mean that that's only people in whom this works, but they are going to try really hard to maximize that effect size. So you have to think about that when you look at who's being chosen, particularly for the early trials. Now, what are your rights? If you sign up for research, what are your rights as a participant? Well, one really key right is that you can always leave the study, okay? You always have the right to withdraw from research. You will find, particularly if it's a drug trial or something like that, that there may be a safety that you have to make. If you've been taking medication and for whatever reason I don't want to be in this research anymore, you can leave. That is always your right. But the study team may say, okay, but we got to wean you off the bed. We don't want to stop at cold turkey. Things like that. So there may be a withdrawal process. You can always withdraw from research. You have the right to understand all of the risks and benefits, and that means asking all the questions you need about what is happening within the trial. You have the right to privacy. And it should not cost anything to participate in research. Your expenses should be covered to a reasonable extent. You may even be paid for your time and if you are being offered a research trial that costs you money to participate, you should really question that process because it does happen, but it's not the standard for well-run clinical trials. So what are some really important concepts that you need to think about and understand for clinical trials? So there's just three words that are thrown around a lot. One of them is placebo. So placebo means that there is some form of ineffective treatment that is offered to try to allow to compare the new treatment with no treatment under identical conditions. So some new drugs are offered in placebo-controlled trials. Some of the people get placebo, and some of the people get placebo medication. Usually, that then involves what's called randomization. That means people that get the placebo versus people that get the new drug is decided by a flip of the coin, completely random. It can be done with placebo. It could also be done with what's called the standard of care. So if I typically treat a given infection with that, we can compare the standard of care. You would never want to see a placebo used in a condition where there is a decent care. So you wouldn't want to take that same infection and say, you can get nothing, or you can get my name to do antibiotics. But that's not right. You should be comparing. And then finally, blinding. So blinding is the process of trying to avoid our own influence on what we think should be happening, might be happening. So in single blinding, the participant is not aware of which treatment they've been randomized to. And then in double blinding, neither the participant nor the study team, the people who are actually taking therapy and deciding if you're getting better or not, know what's going on, because it is very, very easy for all of us, both participants and researcher, to unconsciously, in our hope that this new treatment is going to do better, give a tribute benefit that should. So what do you need to think about when you're deciding about a clinical trial? Well, key things are back to the same things we've been saying, risk and benefit. So when you think about risk, you want to know about what possible harm could happen if I take part of the study. What could go wrong? What could happen to me? What's the level of that harm? So is it inconvenient or is it actual injury? And then what's the chance of that happening? Typically in a clinical trial, there are common but mild complications or side effects, and then rare and serious. And you kind of want to dive into that to understand what that is and what do we know about the treatment. And then the potential benefits. So a well-designed and well-executed clinical trial will provide the best approach so that you can help others, contribute to the knowledge of new treatment and procedures, and also gain access to maybe a new treatment before it's widely available. The questions should I ask? Well, there's 1,000 of them. There are so many questions that we need to consider, and which one to ask may depend on the nature of that exact one. But you do want to think a lot about what's the purpose of the study, what are they trying to do, what are they trying to prove. You know, we looked at those different phases. Is this a phase 1 trial where they're not actually trying to prove if this drug works? They're trying to just prove if it's safe? Or are we actually at phase 3? Maybe there's some pretty good evidence that this works, but we actually kind of start with subpopulations that it works in. All of those are really important questions to have. Now, with some of the inherited arrhythmias, some of the trials that are coming out are gene therapy trials. So another really important question to ask, what are the implications for my access to this kind of treatment before? Because for a lot of gene therapy trials, you got one shot. So if you've only got one shot, you want to be involved at the very first access so you can be the first in the door. Maybe you do. But if they're still figuring out the dose, and you might get a low dose that's less effective, and that means when the drug is proven and you come around again, you can't get it. You need to know that. And I'm not saying there's a right or a wrong, and if you happen to get the right dose and you get it early, you're going to be really psyched, right? You got first access, which proves to be a fantastic treatment. On the other hand, if you get involved at a stage when the dose isn't known yet, and then you can't have access to it later, you got to know that. You got to ask these questions. So it's really, really important to talk not to the same. See if you can find experts in the field, in the area, who are not involved in the research, who might be more likely to bring up some of those more difficult questions. And this is not true of all gene therapy, but there are some kinds where this is, for us in ethics, this is the concern that we have. Because people who are enrolling early are taking on the risk. Benefit is not quite as clear. So you have to decide for yourself where you and your is and what's needed for you and your family. And for some, it may be high enough that it isn't acceptable, right? But you should make that. Somebody else should make that. So just talk to everybody and don't feel like there are any questions that you shouldn't ask. What happens when the trial is done? What's the next phase? So in a phase 1 or phase 2 trial, that's the basic safety one, right? So if the safety is okay, they're going to move and they're going to start planning for trials. But a lot of times they will find in the phase 1 that it's not safe. You do a lot more phase 1 than we do phase 2, more phase 2 and phase 3. So it may just be like oh, actually this is good, we're not looking at something. When you get to a phase 3, hopefully you've put the majority of those safety questions behind you, and you're really looking to see what the efficacy is. So the research will examine those results and really try to decide whether this overall offers medical benefit to people. The results from a clinical trial should always be published in a peer-reviewed scientific journal. They're not always, but they should be, and you should always be advocating for that. The transparency of this information is what helps all of us learn. And then the research team should always be sharing those results back to the participants. Sometimes those results come even years later, and that can be really hard to do, but just know, as participants, you always have the right to the results of the trial. So how can this clinical research make a difference to you, to your family? Well, first of all, this is how we learn about new procedures and new drugs. And everything that we have learned, all of the medications that we all take now, are all the products of years and years of research. And part of that process is so valuable, not just to the people in the research, but to everyone who goes on down the line. And it builds collaboration across communities, and it builds patient researcher partnerships that are incredibly important. But you should be an equal partner in that, right? You might have noticed that I have not used the word subject. You are a participant in the research, and you should be treated as such. Thanks very much. I don't know if we have time for questions.
Thank you, Beth. I failed to mention that Dr. Stephenson is also a member of the SADS Board of Directors, so we appreciate that very much. Yes. Any questions?
I know you guys are behind time, so.
Okay, all right. Thank you very much. Have a safe trip home. Okay, I'm looking for Dr. Pete Aziz. May I just take our break? See if he's outside, Sharon. Thanks. Could take our quick break now and maybe cut it down in time. If you all want to take a stretch break or walk down the hall to the restroom, and then we'll reconvene here in about 5 minutes. How about that? Test 1, 2, 3.
Sure. Okay. That's it. Great, thank you. Okay, I'll grab this one.
Okay, we're going to get started here again. And our next presenter is Dr. Peter Aziz. He's from the Cleveland Clinic. He's also the chair of our SADS Medical Education Committee and volunteer all around, I want to say. All right. So I'll turn it over to you, Pete.
Can everybody hear me okay? Oh, wow, that's really loud. I tend to project, well, I'll use this for the audience, but I don't, if this is too loud, just let me know, or if you can't hear me, let me know. Good. How long do I have? 2 hours? Perfect. 15, okay, we'll move quick. All right, everybody. So as Marcia said, I'm Pete Aziz. I'm a heart rhythm doctor at the Cleveland Clinic. I deal mostly with pediatrics, so I see adults, particularly ones that have inherited arrhythmia disorders. You are all families of SADS patients, is that right? Or SADS patients yourselves, is that accurate? Okay, great. Well, nice to meet you all. We're going to talk about sports and exercise as it pertains mostly to SADS conditions, of course. So why is this an issue? Why aren't we talking about, driving and having a SADS condition, or taking your children to school and having a SADS condition? And it's because there probably is a signal here. This is an old study, and I wanted to use an old study more than 20 years ago because this is not a new concept. Domenico Corrado is an Italian physician and looked at the probability of having a cardiovascular event if you're an athlete versus a non-athlete. In the risk ratio, you're almost 3 times more likely to have an event as an athlete as a non-athlete. We'll see some more data to suggest this. Looking at diseases specifically, these are a bunch of cardiovascular diseases: ARVC, coronary artery disease, coronary anomalies, mitral valve prolapse, so on and so forth. There is a higher odds ratio just about for everything. ARVC tends to now be the poster child for danger with exercise. But you could say across the board, the athletes seem to have more events, and that's what that means. What about our NCAA athletes, or collegiate athletes? And this is Kim Harmon's data from circulation. They identify patients through NCAA memorial resolutions, which is essentially a list of patients that have unfortunately experienced sudden death, and Parent Heart Watch, which you may be familiar with, is a nonprofit organization that does internet searches very often to look for unfortunate cases. And this is over a 5-year time frame, examining nearly 2 million athlete years, and they discovered 273 deaths in that time frame. And the majority of those deaths were non-cardiovascular. The majority were accidents, as we should expect, and there was a modest representation of cardiovascular disease. So 16% of these NCAA athletes that experienced sudden death had a cardiovascular cause, as I said. And this is relatively sobering data here that shows the relative risk increasing as we move down the slide. So if you look at the top is looking at high school athletes in Minnesota from a study that was performed. Then we look at Italian athletes, and then Division III, II, and I athletes, and then finally NCAA Black athletes, which have the highest risk relative to non-athletes for playing sports. Again, very sobering and alarming news, I would say. So Barry Marin quotes the term the paradox of exercise, and what he says is, however, the consequences of exercise are more complex than they might seem at first. In addition to having the benefits mentioned, vigorous physical exertion may also trigger sudden death and myocardial infarction, particularly in persons who are not accustomed to regular exercise. So if you drag the sedentary person and have them shovel the snow in the winter, that could be the perfect storm, and that's certainly what we see clinically. So some, according to Dr. Marin, some is good. Excess is probably bad. So should we therefore encourage regular exercise as protective to avoid the sedentary person all of a sudden becoming active? Everybody should just exercise. Now, that's the thought. What we know about our patients, our SADS patients, is that there are very specific triggers that can induce disease. They can induce arrhythmia. Swimming for a long QT1 patient is one specific trigger. Alarm clocks for a long QT2 patient. Sleeping for a long QT3 patient, and a postpartum period for a long QT2 patient. This is just one syndrome, long QT syndrome, and you see that the triggers are kind of all over the map. What links sleeping and swimming? Nothing, right? So the diseases are quite different, even though they're labeled on the surface. The devil is in the details, and I think that's where we have to have very thought-provoking conversation. I'm going to tell you about a patient of mine. This is a 21-year-old collegiate athlete who collapsed while she was playing soccer. She was running sprints, playing soccer her entire life, got to obviously the college level. She was not only doing a lot, but she was good at it. She collapsed, and her coach noticed that she was not breathing and she had a pulse. So appropriately and very quickly grabbed an AED and placed the AED. Turned the AED on as the AED being turned on. Started breathing, does not remember what happened, but had a full recovery. Was sent to a local emergency room and had not to recognize what she is. But this shows very, very clear to somebody like me, long QTC. This is not a subtle case. As a matter of fact, her QTC was 540, which is much, much longer than it should be. So with that history and with this ECG, this is a long QT syndrome. So I think some of you in the room at least know a bit about long QT syndrome. The heart looks totally normal. It is a microscopic disease in the iron. It causes sudden death in about 1,000 patients, at least that's what we know of. There are probably more than that, but at least that. Mostly in the young, and the hallmark presentation is having a passing out spell and not feeling. Patients will describe all of a sudden they woke up. Exactly what our soccer players. And this is the arrhythmia. This is what it looks like. So, looking at the very bare bones crux of this arrhythmia, what we look at when we see the action potential of the heart muscle cells contracting, the squeezing of the cell is that stroke upward, and then the recharging of the cell, the relaxation of the heart muscle is that downslope. And in normal patients with normal ion channels, that's supposed to happen very rapidly. But if you affect the potassium ion channel like we do in long QT syndrome, the inability of the heart to recharge quickly causes that QT. That's the crux. That's what gives people with long QT syndrome. But like we talked about before, depending on what genotype you have, the triggers are different. You can have exercise-induced triggers in long QT1. You can have emotional triggers like the alarm clock that was still in long QT2 or long QT3. And not to belabor the point, but not only are there different subtypes and different frequencies on different genes affect different parts of the action potential, have different triggers, but it also has different responses to therapy. Where in long QT1, beta blocker therapy is incredibly effective, so effective that we consider our long QT1 patients protected to the point where we don't towards restriction of the patient. And then some others we might. And this is to hammer that point home down further. That top, this is a Kaplan-Meier curve we call, which shows event-free survival. So what we're basically saying is this curve shows the amount of patients that have an event makes the curve go lower. Patients that don't have an event, the curve stays up high. You want this curve to be high. The higher that it is, the better. The long QT1 patients that are on beta blockade, they have very rare breakthrough events, whereas in long QT2 or 3, they may have a little bit more. So what type of long QT patient you're dealing with matters when it comes to sports. And we all are familiar with, or those of you that have long QT syndrome may be familiar with the Natalol story, and that's typically the medication prescribed or propranolol. But this is now the reality of the situation, or at least this was the reality of the situation when I finished training in 2011. This is called the 36th Bethesda Conference, and this is a summary where they stratified sports basically into this 9-box diagram, where the high intensity, high dynamic sports are up there on the top in red, boxing, community cycling, and the low intensity are in the green. And what we said back 15 years ago is if you have a SADS condition, this is all you could do. You're limited to the Class 1A sports. And I know these Class 1A sports because this is what we regurgitated to our patients every single time we saw them. Cricket, curling, golf, bowling, right? I'll never forget that. And everybody shaking their head. This, unfortunately, was the reality back in the day. So this is what we told our families. This is all you can do. I don't know if anybody here knows much about cricket, but Our cricket players are very offended by this. They say, cricket is not a low-intensity sport. It should not be teamed up with golf, which is, right? But I'm not going to get into those. I see little children in here. I'm just going to show this slide very quickly. It is modestly offensive. So when we tell our families this, do you mind thank you very much. The earmuffs and so this is what our families say, right? All right, now we're good, So we've met a lot of resistance telling our families this over and over again, and it frustrated us as clinicians to have to tell families with athletes that, hey, your kid can no longer do what they want to do. So Dr. Ackerman from Mayo, who we all know, said, let's study this. And he looked at 130 patients in his Mayo cohort. This was, years ago. And in 650 athlete years, there was one patient that had an event who missed their beta blocker dose, who happened to be a very high-risk patient. And that patient was not competing in sports at the time, was warming up. When I was a fellow, I'm at the Cleveland Clinic now, but I was a fellow at the Children's Hospital of Philadelphia. We pulled our data at CHOP and found very similar things, 213 patients and 755 athlete years. And there were no events during sports. There were 2 patients that had events. One was a long QT2 patient that had an influenza A illness and had an event while in the hospital being treated for influenza. And the other was running in their backyard. None of these patients are experiencing life-threatening events while they're active. Studies now that show the same thing. So this and the Dr. Ackerman study and our study compelled, I think, the powers that be to say, maybe we missed the boat here with our Bethesda 36. Maybe we should be a little bit more liberal. So if we look at this yellow box here, it says concealed long QT syndrome. That means that you have the gene for long QT syndrome. You don't have any evidence. Right? For those patients, they used to say in Bethesda 36 that you're not restricted. And in the next iteration of task force guidelines, we said we agree. Those patients should not be restricted. For the symptomatic patient, for the patient that has evidence of disease and has had an issue before, you're restricted in Bethesda to class 1A sports, cricket, curling, golf, bowling, riflery. Now, there's no restriction unless you're a swimmer, but even then we can massage that a bit. And what I love about this is that even if you are symptomatic and we put you on medication, because medication is so effective, then you can do whatever you want. And then lastly is the patient with a defibrillator, who we consider the high-risk patient. They say class 1A, but you can also consult an expert. And if that expert channelopathy doctor, that expert electrophysiologist thinks that you can play, then you can play. This totally revolutionized what we as clinicians can do, and really what families can do. So the question, just for the Zoom here, the question was, what about the patient that has a QT interval over 500? And I'm going to give you the elusive answer. It depends. So if that patient has a QT over 500 and they're 10 years old, so they have long QT syndrome type 1, and they never take a beta blocker and they're not interested in doing it, I would say that's a risky situation. If that patient is a 35-year-old and wants to play golf and is, religious about taking their beta blocker, I would say go ahead. So it depends. I think the conversations in reality that we have goes a little bit deeper than this. We have, and we'll get to this in a second, we have the shared decision-making conversation. Okay, not what the guidelines tell us, but for you, Mr. Smith, or for you, little Johnny, how do we dissect what your risk is? How do we employ what we know about risk and come to a decision together? As long as we both understand the risk transparently and the family wants to do something, we very infrequently do. Talk a little bit more about that. So this is the Task Force 10, and what Task Force 10 tells us to do is treat the patient first. So make sure that your patient that you're allowing to play sports is on what we all agree upon as normal treatments in 2024. So this is from our SADS website. This is the link to the medications that a long QT syndrome patient should not be taking. By the way, I'm continuing to talk about long QT syndrome. I'm I'm just using that as an example that can be translatable to some disease to others. But long QT syndrome we know quite a bit about. Don't take medications that you shouldn't be taking. It also tells us to avoid dehydration, make sure you're hydrated at all times, and make sure your electrolytes are in balance. So if you're a patient that has been vomiting for the last week and can't keep anything down, you probably shouldn't be playing. And then this is part of the shared decision-making conversation. We say, well, what do we know about that and where is it? And who around this child or this adult knows how to use it? A lot of our conversation tends to be, what if the worst case scenario happens? Are we prepared to have trained providers around? Do we have people that coaches understand what is the step 1, 2, and 3? If we're all on the same page, and God forbid an incident happens with a patient on the field, if everybody knows what to do, the probability of a favorable outcome is actually quite high. It's those circumstances where AED isn't around. So this is the shared decision-making paradigm where, to your point, there is no line in the sand as far as I'm concerned to say this patient, no circumstances based on what we're seeing. It is let's add up the pros, let's add up the cons, and have that conversation. We provide that guidance, but really the decision-making process is everybody, not mine. So let's go back to our soccer player. She was diagnosed with long QT syndrome type 1, eventually through gene testing, as we talked about, it was obvious. We started her on a beta blocker. She was asymptomatic for a year, and after talking to her family and her, decided, and the school, to be fair, decided that she could play in her senior year, and she did, and she was very grateful. So are there sports restrictions left in long QT syndrome? This is from Dr. Ackerman. Genetic discrimination needs to stop. We need to guide and route rather than just pick them. A lot of that will resonate. I wanted to make this as short as possible, though, add some data into it for the purpose of the conversation. I'm happy, Marcia, to take questions. Is that all right? Have time for that? Okay, great. What questions do you guys have? Sir?
I'll bring the mic over so our virtual Zoom listeners can hear the question.
So in what situations do we need to be thinking about keeping electrolytes in balance and drinking Gatorade and things like that? And in what situations is it just they need to be drinking water all day?
The easy avoid the question answer is all the time. But I think in special circumstances where you think somebody might be particularly at risk, and I use the example of somebody. Those are the patients that probably should be resolution. What we see, the reality of the situation is what we see, practically speaking, is our undiagnosed patients and even our diagnosed patients typically require multiple hits, right? There has to be more than one thing going on all at once to cause these very rare catastrophic events to happen. What we're trying to do is control everything that we can actually. Electrolytes and fluid hydration, taking your medicine are things that doesn't work all the time. Success. Thank you. Yeah.
I'm fairly certain this is going to be a it depends answer. We've heard from doctors to keep the heart rate below 120. I know there's a lot of genes. Keep it below 120, keep it below 130. It depends, right?
Yeah. Unfortunately, there's no data. I wish there was. It would make our jobs a lot easier. There's no data that says if you keep a patient's heart rate below this number, they'll never get into trouble. The reality is, and we see this data based on patients that have had defibrillation events, for example, through an ICD. We can see what happened before they went into an arrhythmia. They're not always fast. As a matter of fact, sometimes they're even slow. So it depends. But there is definitely not a number where we can say somebody's going to be safe.
I had one. Do you have any resources or studies for facilitating conversations when people would rather have the child not participate, or coaches say, well, we don't want them to participate because of the risks? Are there resources to help facilitate those conversations, or we can point them to, versus them just saying, we don't want the kid to play?
Sure. I think SADS is always a good resource, and I think the people at SADS understand this equation and conversation very well. But I think ultimately you're going to have to find a provider that knows how to do it. Without that, that conversation can be very abrasive and dismissive, heartening when a doctor says you can't play. As a matter of fact, an ARVC in a cardiomyopathic disease, it's not very common, but something that we see. Sports is a totally different beast, and sometimes we do have to have that conversation. Maybe exercise is not the right style, but you got to know how to say that, and it's just challenging thing to do. The other side of this is mental health support is very, very useful. I'm not a mental health specialist, and nor should I be, because I don't have that expertise. But we need those folks along with us to have those conversations. So oftentimes they're part of that.
When talking about sports, the Bethesda chart had contact, again, in cardio as kind of two axes. Can you talk about a little bit, maybe in your experience, about contact sports and whether or not, well, I guess, what are the concerns there, and you know, or any examples you have of kids with that and some of the conditions?
Actually, the chart that we saw didn't show contact. It was dynamic, and it was, let me pull it up. I don't remember what the oops, sorry about that. Forgot he was in there. Did I pass it already? Oh, sorry. Wait. There it is. So it's, dynamic and increasing static. So it's not quite contact, but the contact issue comes up usually in one situation when a patient has a defibrillator or a pacemaker. Our concern, and I didn't put this data in here, but I'll share it with you. Our concern when patients have devices is if they receive a blow directly, let's say they play football, they receive a blow directly to the device, what is the probability that the lead breaks or that the device malfunctions as a result of that contact? And data has shown, recent data, as a matter of fact, has shown that regardless of whether somebody's in contact sports or not, we have not seen adverse outcomes as a signal to say that we shouldn't be allowing our patients. It's a reasonable theoretical risk if it hasn't panned out. Hope that answers your question.
Hi. So for the example of the soccer player on Nadolol, how important is it to make sure the frequency is the same time every day if it's a daily dose? And is there a specific time of day that the medicine should be taken? For example, if you take it in the morning, but you'd play sports in the evening.
Yeah, that's a great question. And I didn't get into that either, but that is really a genotype-specific question. So if you think about long QT syndrome as a disease, most patients with long QT syndrome have events during sports during the day. What we want to make sure of is their beta blocker. Usually prescribe Nadolol once a day for patients that are older than 8 or 9 or so. So if they're on, this is a 21-year-old, if she's on Nadolol once a day, we want her to take that in the morning. In fact, that during the daylight hours when she feasibly could be exercising. In long QT syndrome type 2, you guys saw the alarm clock cartoon. Those patients wake up with their alarm clock first thing in the morning. They don't have Nadolol in their system yet. They actually have to take their night. When they do wake up, there's Nadolol in their bloodstream to protect them when the alarm clock goes off. So it depends on what kind of genotype you have. But having said that, the consistency in taking it at the same time every day, around the same time, is important. Sure. That's a great question. People always ask that, especially around Halloween time. Yeah. The haunted, I don't have a clear-cut answer for that. But for most of our patients, we just describe the risk. We say, if you have, this is a long QT type 2 risk, theoretically, for haunted house, right? Emotional startle, there's definitely haunted house written all over. So we say if you get the bejesus scared out of you and you have long QT syndrome type 2, that could be an arrhythmogenic trigger. So a lot of people hear that and they're like, well, this is it. Depends on what your value system is as a haunter. For long QT1, roller coasters can be a trigger. So for those patients, this is a trickier conversation. So if you're on, I live near Cedar Point. I live in Cleveland, Ohio. Cedar Point is right down the street. All of our patients go to Cedar Point all summer long, and they always ask me, like, right when May hits, they're asking, and junior ride on the roller coaster. I'm like, well, which one? Who's going to be on the roller coaster? And the reason why I ask those questions isn't to be obnoxious, but there are some roller coasters that are 5 minutes long. So God forbid, remember, we always think about worst case scenario. Going up the first big hill and coming down and you have an arrhythmogenic issue, have cardiac arrest. It's going to be minutes until you're back. Then who's standing there watching you when you get back? It's the roller coaster operator, right? Who's like a 15-year-old kid. Nothing against 15-year-old kids, but they may not be equipped to identify sudden cardiac arrest, get them out of the harness, get them on the ground, start CPR, get an AED. Lots of steps there that can go wrong. So I don't say don't ride a roller coaster. I say think about it this way, right? And make your own decisions about it. And oftentimes they hear that and they say, well, we'll do some short.
Okay. Oh, one more question.
Just speaking of these length of times, are there in this grid of risky sports, I'll call them, is there a heart behavior associated with sprinting versus long distance versus high intensity? I was a distance swimmer, not a sprinter.
Sure. This chart has nothing to do with what's been defined as arrhythmia risk in people with SADS. This chart was devised by exercise physiologists that say your metabolic demand is the highest in that red corner and the lowest in that corner. So we, as scientists, we said, okay, well, if it's the lowest in that corner, that must be the safest. There's no data to show that, right? It's just what we think should be safe. Fortunately, in our world, there are not enough, thank God, there are not enough people having arrhythmic events in all of these boxes for us to study it and say that really is the worst box. We just don't know that. That's why cricket is first. We don't have that data, right? This is just a bunch of people in a room that decided this is what the box should be.
All right. Thank you very much, Peter. We appreciate your time today. All right. Our next presentation, we're honored to have our Chicagoland Brittany's Trees volunteers. We have Jim Guthrie, we have Sharon Lantino, and Tony Valine. And so they're going to talk about one of our most successful fundraisers for the SADS Foundation, and they're going to tell you all about it. Get your presentation up.
Get the good microphone. All right. Well, thank you everyone for letting us present, and thank you SADS for giving us the opportunity to give you an overview of who we are, what we're all about. This is really going to be Sharon's story, but what I'd like to do is I want to kick it off. This is a fundraiser that we're going to talk about, and it began 20 years ago. I live in Carroll Stream from Illinois, so I'm about 35 miles straight west from where you're sitting like right now. And my next door neighbor is Tony. He was married to Mary, and had 2 kids, Anthony and Brittany. And I've known Tony for maybe a few years at that point in 2005. But got some bad news that his daughter had passed away in February of 2005. And as a next door neighbor, as a new father, having 3 daughters that were, 6, 5, and, maybe 18 months, they looked up to Brittany as being kind of like a mother hen. And Brittany at the time was 8 years old. So when she had passed on in February of 2005, obviously it was a dramatic impact, not just to the Valine family, not just to the neighbors, but also to the school district and just to the local friends and everybody that knew Brittany. Brittany was a very charismatic, outgoing 8-year-old, well beyond her years. And I wanted to do something to honor her memory. And I did go to the Carroll Stream Park District and say, hey, let's see if we can rename a park in her honor, call it the Brittany Valine Memorial Park. That did not pass. And then here came the holidays, here came Christmas. And so it was an idea that I would go up and talk to all the neighbors, 22 homes on our street in Matthew Lane, and say, hey, for X amount of money, you're going to get a tree in your front yard. And it was kind of challenging because I don't know what I was doing at that time. Because people are like, well, no, we don't want a tree. You know, we're going to plant it. We have a tree inside, Christmas tree inside. I'm like, no, we're going to set it up. And it didn't go well the first year because when I was knocking on the doors, I'm a horrible door salesman. They said, okay, well, who do you make the check out to, or who do you give cash to? I'm like, me, Jim Guthrie. You know, they're like, all right, we don't even no idea where this is going to go. So the first year we did 22 trees, and we donated $248 to the SADS Foundation. Got a letter from Alice saying, oh, the Guthrie family, thank you so much. And I'm like, no, it wasn't the Guthrie family. It was all the neighbors in Carroll Stream that did it. And all the neighbors were coming by and saying, hey, can we participate in what you were doing as well? So the first year went from 22 trees, then it went to 60, then it went to 100, then it went to 200, 500, and 1,000. And we are now 20 years later, and we're going to deliver and set up and decorate over 2,100 trees. And instead of, thank you. And instead of donating $248, now we're donating $50,000 to the SADS Foundation. So the star of this presentation really is Brittany. Sharon and I and Tony, we're 3 people, part of a 350 volunteer organization, because we deliver trees all the way to DeKalb, we go to Libertyville, we go to Chicago, and we go south to Tinley Park. And there's no way that just a simple group of neighbors on Matthew Lane and Carroll Stream can do it. So we do 2,100 trees to 45 towns throughout Chicagoland area. How do I get to the next? Oh, perfect. So we've evolved. I want to let everybody know we do have a website to where you can order your trees. We also have T-shirts. We are dressed appropriately. Only the special people get the hoodies and the shirts. So you can go check it out where you can order a tree, you can order a shirt, and you can also make a donation. The other aspect is that we have a Facebook page for Brittany's Trees where you can go look at that. We post a lot of pictures. It's a group. It's not a page, it's a Facebook group. So you can actually make a comment. You can say whatever you want on it. We have a new website, so you're actually going to see real time how people are saying, hey, I didn't get a confirmation email, or hey, did my tree get ordered? And I have to respond in real time so that you guys know that it's a very interactive, group. But what you can see from this picture right here is that of the 350 volunteers, it's made up of everybody, neighbors, adults, it's kids, it's children, it's Cub Scouts, Boy Scouts. Everybody comes together on the Saturday after Thanksgiving, to deliver, set up, and decorate a tree. You may ask, okay, how much is the tree? Well, for $68, you get a 6-foot Scotch pine or Colorado blue spruce tree. You get a stake, a post, which is a 6-foot post from Home Depot. We have a pounder to pound that post in. You get 3 sets of white lights, and you also get cable ties to do that. So full disclosure, we're selling it for $68, but our real cost is probably around $48 for all of it. So if you look at that, we're donating roughly around $20, $21 per tree to the SADS Foundation. So if you look at the math, it's going to be, okay, 42, whatever, but we're able to donate more because we have sponsors, community sponsors, individuals that say, hey, I want to give $250, I want to give $500, I want to give $1,000, I want to give $3,000, I want to give $5,000 to your charity because I know exactly where it's going. All of this, all of the money that we make and do goes to the SADS Foundation. Kind of cool. There's only 2 people on that banking account. It's Alice and it's Tony. It's Brittany's, dad, so. The other thing you have to think about, or what we do, is that we also have trailers. So we have many different teams that show up in Carroll Stream on a Saturday after Thanksgiving. We have a big tent. Part of the thing of being a sponsor is that you can see that you get a banner. It's good promotion for the people. It's also good for us because it helps reduce the costs and the expenses. And we also have a massive amount of people that show up in Carroll Stream and also in surrounding towns. And I will say that, you know, although that we started it in Carroll Stream, it's people like Sharon, it's people like her family, it's people like her daughter, Annie Latino, who said, hey, Jim, this is going back, 15 years ago, where you said, hey, we would like to do something similar in Libertyville. How do we get started? And we had many conversations, and Sharon is leading up a team in Libertyville. She's been doing it for 15 years and been doing pretty good with that. The other way we get awareness and generate awareness and promotion, we're pretty active in our community. We have a 4th of July parade that we attend. Brittany's Trees is doing it. We also put up signs on neighbors' fences, whether they like it or not. We get local restaurants in the town that promote us. We also have sponsors, like I mentioned, and then, kind of did it the hard way, where Tony and I were setting up signs, throughout Carroll Stream, and had to deal with some village people with, village ordinances for signs, but that's okay. We got it taken care of. So like I said, it's been 20 years of us doing it. We do it for fun. We do it for Brittany. We do it for the SADS Foundation. And we have a logo that we, different colors and different logos that we do every year. We're very excited about this year because every 5 years, we're going to go with purple. That was Brittany's favorite color. And so as a reminder for everybody on why we're doing this, we're doing it for Brittany. But this gives you kind of like an idea of how we, go about, the festival and the event. I will say, too, that we've been fortunate and lucky that for people have been promoting Brittany's Trees through the media. We've been on Fox News. We've been on WGN. We've been on Chicago Today. I encourage you not to go look at those because I've been up there and I've been nervous and I sound kind of goofy and funny. So go ahead, you guys can go look at them. But I want to hand this off to Sharon, and I can't stress enough that people around the country, people in the Chicagoland area are always asking, how do you get started? And my hat is off to the Latino family for not just saying, okay, we'll do Libertyville, but then she would call me and say, hey, Jim, there's a home in Wakanda, or there's a home over here, can you do it? I'm like, I don't know, I think you can. And then it grew. So, Sharon Latino.
Thanks, Jim. I couldn't do it without these guys because they run everything so smoothly. It makes everything that much easier. And as Jim said, it is really fun. Quick story about me. I do have long QT syndrome type 1, and so do my 2 daughters. And as Jim mentioned earlier, Annie is the one who encouraged me to start doing a Brittany's Trees in our town of Libertyville. And I now have a granddaughter who's 2 who also has it. So we are living and thriving with it. But what I did is I have a team of friends, high schoolers. Their kids have to do service hours. So this particular team is actually driving in from Dayton this year to help me because they moved and they love it so much. And so we, again, just go around. This is one of our first times we had to go out to Carroll Stream and pick up our trees. Funny story, we lost one on the way home. It fell off, but Jim was good. He gave us some extras just in case. So, but anyway, that is kind of a funny story. But they do now deliver to me because we're up to probably 70 trees just for our little town, which is a lot. It takes a couple days to put those up. This is them delivering, and they're guys that they have come out to my house. It's about a 40-minute drive to my house from Carroll Stream. And there's the lights you can see, another group, and we just gather. And these families come back year after year to help because it is just a fun day to go out and start the Christmas spirit in your town. And then it's fun to drive around also and just see, Brittany's light shining on those trees. So this is just their group. And it's really, like I say, it's really easy. These are my two daughters. It's probably very old. Oh, it's very old. It's 9 years old. And so that's our story. It was very easy to start because whatever time, if you do it in the Chicago area, you just attach on to Jim's, Brittany's trees. You order it, all the money goes through them, and all you have to do is gather the helpers to help you put up a tree. But if anybody is interested in talking to me more about this, it really is a fun day and a good way to start that holiday season. So I do this too because my daughters are lucky to be living and thriving with long QT syndrome, and we do it to honor Brittany because we like that she lives in all of us, right? Anybody have any questions? I'm here all weekend. I don't know if you guys are staying around, but I'm here all through tomorrow too.
Thank you, Sharon and Jim and Tony. So appreciate your help. Thank you. Round of applause here for all of them. I'd like to introduce my colleague, Ms. Anna Goodson, is our Director of Communications, and she is going to introduce our next presenter.
Hi, everybody. It's been incredible to meet you all today. I've been lucky enough to work with SADS for 4 years, and I've seen so many of you on Zoom, and today is my first time meeting many of you in person, and it really has, I've cried multiple times. It's meant a lot to me to see you all in person. And the person I'm going to introduce who's going to be doing our next session is somebody that I met my very first week working for SADS 4 years ago. Katherine Standefer is the author of Lightning Flowers, a finalist for the 2021 Perkins Prize in Nonfiction. The book was also a New York Times Book Review Editor's Choice and Staff Pick, named one of the Oprah Magazine's best books of fall 2020, and has been featured in People magazine and on NPR's Fresh Air, which is where I first heard it, my first day of work, which was really cool. Standefer also serves on the Patient and Stakeholder Advisory Board for the PCORI-funded ICD study, and Lightning Flowers is now required reading at Harvard Medical School. It is a book about her journey with long QT syndrome and an ICD, where the elements of her ICD come from in the world. We'll actually be doing a book signing at the reception as well. We'll have books here for purchase from a local bookstore if you haven't read it. Katherine has also been a volunteer and advocate with SADS for many years. After the publication of Lightning Flowers, she was part of our first ever SADS book club, joined SADS Live, and was part of a SADS panel on ICD experiences. She's also published an op-ed in the New York Times and presenting with us about the importance of testing for SADS conditions. It is truly a pleasure to meet her in person after spending years working online with her and her energetic and giving heart. So please welcome us in joining Katherine Standefer to lead us through writing our stories.
Thank you so much, Anna. Okay. Just so I can see when they do appear. Can you all hear me okay? I know I've heard a little sound in and out today, so I'm going to try to be really careful about it. It is such a treat to be here. For those of you who don't know me, I actually grew up in this area. So I flew home and got to pick up my sister in Denver and fly with her. Both of us have long QT syndrome type 2. And I always wanted to be a writer, but I had no idea that I would end up writing about heart conditions and medical technology. In 2009, I was 24 and working as a ski instructor and a climbing guide in Jackson Hole, Wyoming, when I randomly passed out in a parking lot. And when I woke up, I immediately knew that my life had changed forever because my younger sister, a year and a half earlier, had already begun going into cardiac arrest when her roommate's alarm clock went off in her dorm room at college. So it has been the unexpected arc of my life to combine what it means to be a writer with the experiences that have found me. On the day that I woke up in that parking lot, there wasn't a book that I could check out that really spoke to the experiences I was about to have. And so if any of you have read Lightning Flowers, you may have seen that at the very beginning, the dedication is to the girl in the parking lot. Here is the book you needed. But this is such a special event to be included at because many of you are the girl in the parking lot, theoretically, even though you have your own versions of that story. My adult life has largely been spent working on this book. It took 8 years to write. It also then has been spent working with other writers to tell their stories. And I've worked a lot with folks who are working on illness narratives and trauma narratives. I think all of you can probably feel, if we take a minute to like just be in our bodies a little bit, it can be a little bit intense to talk about this all day. Maybe some of this is scientific and taps into your analytical brain, and then someone will say something else that you're like, oh, that happened to us, right? And it's maybe a passing moment in your body, or maybe it's actually been overwhelming enough that you've stepped out for a moment. And that whole spectrum makes sense. And so what I'm going to do today is lead us through a few writing exercises that allow us to connect a little bit with the stories that may have been bubbling toward the surface and then coming back down, bubbling up, coming back down. Or maybe you were open about sharing these stories over one of our breaks. But I think it can be really grounding to bring these stories into the room. Let's see. So I think where I want to start is just by asking folks to take a second just to feel your body. I know it can be really uncomfortable to move your body in a room full of people. We're trained to sit so nicely. If you're having trouble, like, feeling your body, moving in your body, maybe just start with your fingers. That's pretty inoffensive. Maybe just, like, get your feet moving under the chair a little bit. Maybe, like, a little wiggle. Check it out, twitch it. I'm just going to open my computer since I didn't get to do that at the very beginning, so hang on. Okay, great. Yeah, take a deep breath. Take a deep breath. So one of the things that I learned early on with telling stories about difficult things is that it's a double-edged sword. There was a researcher named James Pennebaker. I believe he's out of University of Austin, and he did a study a while ago where he had a control group write about random topics every morning for a few minutes, and then he had a group write specifically about difficult things every morning for that period. And what they actually found is that people who were writing about difficult things every day had fewer clinic health visits and improved immunological markers. And over time, Dr. Pennebaker has theorized that there's actually a holding back function in the body. You all know how much work it can take when you're on the edge of tears, or when you're absolutely furious at someone and holding it back. To do that all the time with these big life experiences can actually use up some of our energy. And we may not even be aware of it, right? This is very subconscious. The body is really brilliant in the way it takes overwhelming experiences that we can't process all at once and tucks them away in our body, represses them. Maybe we lose some of the memories. There can be a lot of ways this works out. Maybe we kind of dissociate and just feel floaty in our bodies, and there's nothing wrong with any of that. The cool thing about writing then is it brings us back in touch with our experiences. The key, though, is that sometimes when we touch those experiences, it can be really overwhelming for our nervous system. So to write a book like Lightning Flowers, there was a period actually where I was spending time kind of away from society, off the grid, in this little earth home in New Mexico, and working very closely with a somatic therapist, somatic meaning, feeling the sensations in my body that were happening as I worked on the book, and being able to process those feelings. And I would say, try to write about a surgery. And in order to write that, I would have to sometimes like watch the YouTube video of that surgery and find out the technical names of the tools in that surgery. Because when you're in a surgery yourself, you're just looking up at the ceiling or looking at the nurse, you're experiencing the pain, but you're not cogent enough to explain it to a reader. So I had to be able to bring my analytical brain to that situation, but in between, in order to get there, I had all of these feelings in my body. And so I would just practice feeling what came up and trying to move it, whether I moved it through breath, whether I moved it through sound, whether I moved it through shaking. There were times I was screaming, which I don't recommend doing in your neighborhood at home. But it was very important to get all of that moved out of the way so that I could actually write. So with our exercise today, what we're going to be doing is kind of threading the needle between these 2 points. One of them is it's super good for us to write about our difficult experiences. The other side is we're going to be careful about what we choose to write about, and we're going to pay attention to our bodies so that we don't create too much of an emotional movement for the purposes of being together in this room at the conference, right? And I think you can feel how both of those are possible. Neither of those are where we necessarily have to go together. So I have a few prompts. Did I say everything I wanted to say? Yes. Great. I have a few prompts that I'm going to share, and there are a couple ways you can do this. One of the things that I have learned about working with folks who have lived through a lot of trauma, whether you are the patient or you are a parent who has had to watch really hard things happen, you've gone through a big grief process, you've had to change your whole life, any of that, one of the things we want to do in working with trauma is give people lots of options. So you'll hear me as we roll through these writing prompts, try to give you a few options. If you're not feeling great about anything in particular, find a way to make it work for you. You're not doing it wrong. If you look at the back wall, you'll see some Crayola boxes. We have paper and markers. There's writing paper, there's writing pens there if you don't have something in front of you already. I also have a couple decks of oracle cards back there. So if you just need to engage in a process where you kind of pick through some pretty cards instead of writing, that's okay too. So feel free to visit that stand at any point. If you want to draw rather than write, you can. I'm going to give you writing prompts, but they can be drawing prompts. And what we're going to do is write a couple times on our own, and then we're going to get together in little groups and do some sharing. So I have 2 goals today. One of them is to connect you to yourself. The other is to connect you with the people around you, because this is such a rare group that is sharing all of these stories that other folks in our day-to-day lives may not have in common. So, okay, now we're going to take another breath, and feel free if you got distracted watching me to get back in your body. If you don't have paper, go ahead and grab it, and we're going to go on to our first prompt. How do I? There we go. So one of the special things about my book, in the final chapter, after a big healthcare battle, I make it to the Mayo Clinic, and I get to see Dr. Ackerman. And I will never forget how he began our meeting. He said, "Where did your heart story begin? Tell me your heart story. Where does your heart story begin?" And I thought that was the perfect start for this group as well. So you can consider this start to be any number of things. It could be the diagnosis moment. It could be an event. It could be something that happened to someone else in your family. Whatever feels true to you, we're going to take about 10 minutes and write about where does your heart story begin? And again, if you don't feel like you can write, grab some Crayola, do some doodling, maybe make a map, make it work for you. So we'll be back in a few minutes. Take about a minute and a half to finish up wherever you are. Okay. You want to stop and check out how your feet are feeling. Check out how your hands are feeling. Maybe give your head a little wiggle. We're going to move into the next prompt, and so if you need to twitch at all, take a deep breath. I think a lot about how kids are often doing everything they need to do to process their emotion. It's the rest of us adults that have gotten used to like hardening down. Okay, so for our second prompt, I would love to have you write about one of the heroes of your story. And again, we'll do this prompt, and then we'll do some sharing in small groups and then come back together as a large group. So whatever unfolded for you, your family, your loved ones more broadly, was there a family member, a coach, a physician, a technology, someone who lifted you up, gave you hope, connected you, supported you? Who is one of the heroes of your story? And spoiler alert, it can totally be you. Again, if you feel like you can't quite write about this, but you want to doodle, I invite you to think of someone who could be represented as an animal, and maybe you can draw a picture that represents their energy. So those markers are in the back. I can bring you more paper if you want. We'll take another few minutes to write about one of the heroes of your story. My mother just asked, does it have to be the same story I just started? And the answer is no. You can totally start from a different place if you want. take about a minute and a half to finish up wherever you are. Okay, coming back together. Thanks, everyone. I saw some good writing energy there. What we want to do next is try to connect with 4 to 5 people who are around you who you don't know. So some of you may already be sitting by people you don't know. Others of you may have formed a little crew and then maybe see if you can turn a different direction. But let's just take a minute to try to form groups of 5 to 6 so that we can get into our sharing. Let me just give them their next direction, so hang on. Okay, friends, once you're in your group, you're going to introduce yourself. It sounds like that's already happening. And then either read what you wrote or just share your experience responding to the prompt. It's okay if you want to summarize, and it's also okay if you want to read. And we'll have about 10 minutes-ish here, so make sure you make your way around the circle. If you haven't quite made it to everyone in your group, make sure you have. We have about another minute and a half in this group. Okay, folks, I'm going to transition us back into our large group. I love that everyone is still talking, and I hope you'll hang out at the reception together and finish your conversations. So I'm really curious if anyone in the room would like to share. What was it like to hear other people's heart stories? Was it difficult to tell yours? Did anyone have an experience that they think it could be interesting to share with the group? What was it like to hear other people's heart stories? Was it difficult to tell yours?
So I've been coming to SADS since the first time they had a program. And I would come and I'm listening to Barbara and I start to tear up because she lost a family member. And I've never lost a family member, but I would read the articles in their newspapers or newsletters about people who have lost family members. I would hear the stories, and that would make me cry. And I always thought I had nothing to offer SADS because I had never lost a family member. And then after coming for many years, I realized, well, I know how to live with long CT, and people need to know, how do you live with it? So that's what it brought back for me.
Thank you so much, Barbara. That was really profound. Anybody else want to share what happened in their small group?
Hi, my name is Janelle. And well, I have CPVT, but it was nice to hear different conditions. Because I've only ever known CPVT, and it was nice to see other people's stories with different conditions and different side conditions. It was very new for me to actually hear how people started with their own condition as well.
I was in the same group, so I agree with that. I also would like to say I think it was, for me, heartwarming about how courageous people are. And this gentleman who just spoke, like how he's overcome his challenges, and he's a college athlete and a decorated one. You know, so I think that was really great about the stories, is to hear just how courageous people have been and what they've accomplished despite that. So I thought that was really great to hear.
I would just like to thank Peter for talking about the awareness. I really didn't take any classes in CPR, but I did have to do that on a patient. Happened to be on my wife. She has, come to find out, many years after that, she has long QT3, which also my son does here with us, and we have 2 grandchildren, 3 of them that have long QT3, so I really appreciate the awareness.
Thank you. Anyone else? Yep, one more.
You know, it's always nice to be in a group where you can share things that have been really difficult and really traumatic, and everybody just looks at you with empathy and says, yeah, we've been there too, and our story's not the same, but it is in a lot of ways. And so I just appreciated in our group being able to go back to the very difficult things in all of our lives and the situations that brought us to where we are now, which is a great place. And I think that within our group, you know, all of the difficult situations and the trauma that it caused has still, at least, it led us to being very grateful for having what we have and knowing what we know now. So I just felt a lot of that in sharing with our group.
Thank you. Yeah, I wanted to share that when my book came out, I hadn't been as connected to SADS. I relied on SADS when I was first diagnosed in 2009, when we were trying to figure out what was actually dangerous. This presentation on whether or not kids should be pulled from sports was so on point, because when I was diagnosed, that was still really codified, that you just shouldn't do anything. And I was literally supposed to earn my living running hiking trips in like 1 week. And so this question of like, what is actually dangerous? What can I do safely? Was so profound, and SADS was a real resource for me then. But then I sort of lost touch, and I lived for over 10 years. Let's see, it would have been, almost maybe 11 years, only knowing one other young person with an ICD and long QT syndrome, which is my sister. And so we kind of existed on our own island. And after the book came out, starting to receive stories from other people like me, and especially connecting with SADS and doing some of the book events that we did, was so meaningful, because even though it's hard, it also just feels like part of your life that doesn't always show up in other parts of your life, kind of like joined together, or the experience that was so crazy for you, someone can actually empathize around rather than just being shocked by it. And maybe they do have tips for you. Learning how to live with these conditions and being able to share that, what an incredible gift. So I just want to applaud all of you for your bravery in writing down the story, leaning into the exercise, and sharing with each other. I want you to take a moment and just think about, if you were to summarize the experience you had, writing some of your story today and then also talking about it with others, what is one word that comes up for you that you're going to leave here with? Empathy, strength, support, cathartic, relief. Oh, I love that. Hope, healing, maybe 2 more. Anyone have one right on the edge of their lips? Perseverance. Ditto. Big fat ditto. Thank you. Thanks to all of you. This was really a pleasure. I hope you'll come talk to me later. We are having the signing for Lightning Flowers after this. Copies will be available for sale. We're also having, if you're still going to be in town on Sunday, we're having a book birthday party at Secret World Books. Lightning Flowers is turning 4. And as you may know, most books don't have birthday parties. They kind of come out once, and then, you know, they're kind of old news. But lightning flowers came out during COVID on November 10th, 2020, and so all the bookstores were closed. And so we wanted to celebrate that lightning flowers is still connecting with people and doing its work in the world on a day that we can actually have a book cake. So if you would like cake on some Sunday, come by, come talk to us, and I would love to connect with each of you. Thank you.